Dr Tista Har.
Very interesting topic, hypertrophic cardiomyopathy. We are
You have changed that. Arun Sarkar sir, please continue.
yeah বলছি তো
বলুন.
And the moderators are Professor Dipanjan Bandyopadhyay and Dr. Indranil Sen, and they will be introduced by Professor P.S. Kormukar. Now, P.S. Kormukar, please introduce the presenter and the moderator, and as well as a short, brief topic. Thank you.
Thank you, sir. Yeah, thank you, Professor Sarkar, sir. On behalf of ICP West Bengal chapter, I welcome all the panelists, faculties, my friends, my juniors, as well as the delegates who have joined online for taking active participation in our master class. And this master class this week is going to be has been organized by our North Bengal Medical College, where all of us, almost all of us, all the faculty members work there and do have their lovely memories of working there. And today we have a very dynamic HOD, Dr. Dipanjan Bandyopadhyay. Whenever I call him up for last 4-5 years, I am seeing all the time he is very prompt to pick up the phone and tell me, Pathuda Bolo. So this time also he, on a single call, he picked up the my call and had given his kind consent that he will definitely organize this week's master class from North Bengal Medical College. And along with Dr. Dipanjan as one of the panelists, there is another panelist. He is also equally, academic like Dr. Dipanjan and dynamic also. He is Dr. Indranil Sen. He has done his, postdoctoral course in DNB cardiology, and at present he is assistant professor North Bengal Medical College, Darjeeling. So I hand over the mic online to Dr. Dipanjan Bandyopadhyay, HOD of the Department of General Medicine in North Bengal Medical College, and as well as Dr. Indranil Sen to proceed further to start the master class. Over to Dr. Dipanjan and Dr. Indranil Sen to introduce our presenter as well as to start the proceeding.
Good morning, everybody, and thank you, Pathuda, for the kind words of introduction. It's a privilege for our department to host this master class, and we have with us our student, Dr. Tista Har, who will be presenting the case, which we shall try to elaborate upon once the presentation is over. And Tista comes from Kalimpong with her schooling in the hills, and she's an alumnus of American Medical College and presently pursuing her MD medicine in the Department of Medicine of MDMC. So over to Dr. Tista Har to present the case.
Good morning, everyone. I'm Dr. Tista Har, junior resident of the Department of Medicine of North Bengal Medical College. So my case is a 59-year-old male, carpenter by profession, presented with complaints of exertional breathlessness for 1 year and exertional central chest pain for 1 year. Now, the patient was apparently well 1 year back, following which he developed shortness of breath, which was insidious in onset, NYHA grade 2, initially progressed to NYHA grade 3 over a period of 3 months, and then static for last 7 months, aggravated during exertion, and there is neither any seasonal variation nor any associated wheeze. No fever, cough, expectoration or hemoptysis, no vomiting, giddiness, blackouts or loss of consciousness. The patient had recent bilateral ankle swelling and no history of nocturnal awakenings. The patient also had dull aching chest pain appearing with activities relieved with rest. The pain was crushing in nature, associated with diaphoresis and nausea, gradually worsening, progressively restricting the activities of daily living, recently incapacitating the patient to climb stairs or carry weights. There is no history of palpitations, upper abdominal pain, or periumbilical pulsations, and there is no history of radiation to jaws, shoulders, or upper limbs. Now, coming to the family history, the father suffered from breathlessness, was on inhalers, and died at home following acute chest discomfort. His elder brother died at age of 23 years. And there is no family history documenting asthma, obstructive pulmonary disease, tuberculosis, and heart disease. Coming to the personal history, my patient is hypertensive for past 11 years on medications. He's euglycemic, euthyroid, and no dyslipidemia. He's a chronic smoker for past 20 years. His bladder, bowel, sleep appetite is normal. Now, summarizing the history, so what we have is a 59-year-old male, chronic smoker with 1 year history of progressive shortness of breath and central chest pain, both precipitated by mild exertion, presently of NYHA grade 3 severity. It is associated with bilateral pedal edema and not associated with fever, cough, wheezing, palpitations, or loss of consciousness. Now, coming to the examination, we first start with a general survey. His higher mental functions are normal with average build and BMI of 21 kg per meter square. His JVP was engorged pulsatile. Pulse was 68 per minute, regular, normal volume, bifid, radial arterial wall palpable, no radial or radiofemoral delay. All peripheral pulses are palpable. The blood pressure of the patient was 130 by 70 millimeter of mercury in right and left upper limbs in supine position and 120 by 70 measured over the mid thighs. And there is a pitting edema on bilateral ankles. His respiratory rate is 20 per minute with saturation of 96% on room air. Other vitals are unremarkable. Now coming to the examination.
Do we have a short discussion at this point? Or should we allow Tista to proceed? Hello?
Dipanjan, please have a clinical discussion. Then we will go for investigations and everything.
Okay, so we proceed
What
with
will be the disease and everything.
examination.
Okay.
So proceed, Tista.
Yes. So now coming to the examination of the cardiovascular system on inspection, the precordium is normal in size, shape, symmetry, no precordial bulge. There is no visible pulsation, venous prominence, scar mark, no suprasternal or epigastric pulsation. There is no kyphoscoliosis seen. On palpation, the apex beat is at left fifth intercostal space, 1 centimeter to mid-clavicular line, heaving in character with double apical impulse. Aortic area and pulmonary area are unremarkable. There is a systolic thrill felt over third and fourth left intercostal space, just lateral to the sternal border, no carotid shudder and epigastric pulsation. Coming to the auscultation, the first and the second heart sound are normally heard. S4 is audible, best heard at apex. There is a soft blowing grade 3 by 6 early systolic murmur, best heard over apex, radiating to left axilla and increasing with expiration. Also, there is a harsh late systolic murmur of grade 4 by 6, best audible over third left intercostal space, close to the sternum, better heard at the height of expiration, and no radiation to the carotids. There is no right ventricular gallop. Now, we also demonstrated dynamic auscultation in my patient. So to check for the intensity of the murmur, to check for the change of the intensity of murmur. Now, we did the following dynamic auscultations, which I'll be summarizing in the later table. Dynamic auscultation was done on standing from sitting.
Dr. Dipanjan, Dr. Dipanjan, may I interrupt for 1 minute before going for dynamic auscultation?
Exactly.
Okay, so she has said that there is systolic murmur in the mitral area, but grade 3/6, but she didn't qualify the systolic murmur, whether it's mid-source systolic or pan-systolic or something else. So that
We can
qualification, I
ask
think,
to
is
elaborate
needed.
on the murmur at this point.
Yes,
The
sir.
apical murmur.
Yes, sir. So there was the soft blowing, grade 3/6, early systolic murmur, best heard over the apex and radiating to left axilla, increasing with expiration.
Okay, early systolic murmur.
Yes, sir.
There is also a late systolic murmur, that is harsh.
Yes, sir. That is present over the left parasternal space.
Okay. So from here we can actually come to a disease. What are the causes of early systolic murmur in mitral area and the late systolic murmur in the left third intercostal space, that is neo-aortic area we're talking about.
Yes.
So, early systolic murmur in the mitral area is heard in the mitral regurgitation. It can be heard early systolic murmur, and particularly it is heard if there is associated HOCM. So there is a disruption in the mitral valve apparatus, so in which we can get this early systolic murmur.
এই অডিওটা একটু ঠিক করো তো, একটু খুব ইকো হচ্ছে। ওকে,
ওখানে কোনো ফোনও কি অন করা? ফোন
Whatever you have talked about, that is early systolic murmur in mitral area. Okay, so early systolic murmur in mitral area, if it is really suggestive of MR, so is it really qualifying anyway, whether it's acute, chronic, or severe, something like that?
So this is early systolic murmur is basically indicating acute MR.
Acute MR. Okay, okay, definitely.
So sorry, chronic MR.
Chronic MR in acute. No, you are getting you are mistaken. So acute, you were absolutely right in your early part. Acute MR give rise to early systolic murmur, because in early MR, mitral regurgitation, early systolic murmur, because pan-systolic murmur we are habituated to listen in chronic MR because of the huge dilatation of left atrium. But in acute MR, as there is no much time for AI to dilate, so whenever in early part, while left ventricular blood is being regurgitated to left atrium, there is huge increase in the pressure of left atrium, almost equal to that of left ventricle. That's why the murmur doesn't being carried out to the later part of the systolic part of the cardiac cycle. So only in acute MR, the systolic murmur is restricted to only the early part of the systole of the cardiac cycle. So as you have said that it is found the acute early systolic murmur. That's why I wanted to qualify the murmur. If it is acute, then you can get early systolic murmur in mitral area, and that will definitely be producing acute dyspnea in a patient of acute MR. That is expected.
Yes, Parthoda.
Yeah, please continue.
But possibly this is a chronic and compensated MR. So patient is broadly asymptomatic.
Continue with dynamic auscultation.
Yes, we can proceed with the dynamic auscultation.
So I did the dynamic auscultation on standing from sitting. Next, I demonstrated the murmur of dynamic auscultation on squatting from standing. As I told earlier, I'll be summarizing all the findings in the table format. So next, I demonstrated the dynamic auscultation on sitting from squatting. Next, I demonstrated the dynamic auscultation on sustained hand grip. Next, I demonstrated the murmur of Valsalva on Valsalva maneuver, that is forced expiration on closed glottis. Next, I demonstrated the murmur on passive leg raising. Now, this is the phonocardiogram of the murmur on the left sternal border. So summarizing my findings of dynamic auscultation, we basically saw the effect of the dynamic auscultation on the intensity of the systolic parasternal murmur. So on standing, the murmur increased in intensity. On Valsalva, there was increased intensity during the strain phase, decreased intensity during the release phase. On hand grip, there was decreased intensity. On squatting, the intensity decreased, and on passive leg raising, the intensity decreased. So now coming to the other systems, the findings were unremarkable. So coming to the final diagnosis, so there was this recurrent heart failure accompanied with effort angina due to hypertrophic obstructive cardiomyopathy and associated mitral regurgitation with regular pulse manifesting pulsus bisferiens characteristics in a middle-aged gentleman with family history of sudden cardiac death in first-degree relative.
Now, I think we should discuss here.
Yes.
Dipanjan, to discuss koro.
Yes.
ইন্দ্রনীল করতে পারো যে
So what we have in this case is it's almost a clear-cut case of obstruction which is causing a murmur, and with the murmur being changing with dynamic auscultation. So this dynamic change in the quality of the murmur suggests that it is possibly due to hypertrophic obstructive cardiomyopathy. And maybe we can briefly review the pathology. But the issue is there can be other causes of obstruction to the left ventricular outflow tract, which we deserve to be aware of before we make a comment of HOCM. So if we allow, we have Indranil who will take up the clinical aspects of the case. We will briefly review HOCM over the next 2 or 3 or maybe 5 minutes. And HOCM was first identified way back in the middle of the last century, and it was poorly understood. Because it was associated with sudden cardiac death, there were a lot of misconceptions. And today we know that it is not as bad as it initially seemed to be. And what exactly hypertrophy is a asymmetrical hypertrophy of any part of the LV wall. So it can be significant if it is more than 15 or more limited hypertrophy. And you can call it HCM or hypertrophic cardiomyopathy, even if the limited hypertrophy is associated with HCM established in other family members, or there is a positive genetic test. Coming to the genetic part of the business, today we have identified several genes which are either pathogenic or likely pathogenic. And initially, there were genes which were thought to be more important, like myosin, kitin, etc. Today, we know that there are more profile of genetic variants, but all said and done, almost 30 to 40% patients might come without a genetic etiology. HCM is global and it is spread all over the world, as you can see from this map. For the juniors and for the postgraduates, what could be the other causes of LV outlet obstruction? So, as we all know, aortic stenosis comes to our mind, but for the differential of HOCM, we should remember subvalvular aortic stenosis. And subvalvular aortic stenosis can come in the form of a membrane, maybe a fibrous ridge. There can be obstruction due to coronary artery disease. There can be obstruction due to anomalies of the mitral valve apparatus, anomalous insertion of the papillary muscle, etc., etc. There can even be some storage disorders which can lead to LV outlet tract obstruction, like Fabry's disease. Before I hand over to Indranil for elucidating and analyzing the case in a little more detail, just to brush up, the clinical profile of HOCM can be stable, benign, without any need for intervention. We can have clinically significant outflow tract obstruction, recurrent episodes of heart failure with or without angina, as was the case in our patient. We can have an increased risk of arrhythmias with the possibility of sudden cardiac death, which is the worst. It is also important to mention that more the degree of obstruction, worse is the clinical prognosis. We can have risk of atrial fibrillation, giving rise to thromboembolic episodes. And last but not the least, a non-obstructive end-stage scenario where there is end-stage heart failure, consideration of advanced heart failure therapies, even cardiac transplant. So these are the clinical profiles, and we need to identify the disease because the presentation not only can be varied, it can be associated with various serious outcomes. Just to mention, echo remains the important tool in our hand. Even your chest X-ray or ECG can suggest a diagnosis of hypertrophic cardiomyopathy. But in today's world, the cardiac magnetic resonance or CMR has come to the forefront of the diagnosis. We will not read the slides, but a CMR can identify details in much better precision, including the outflow gradient, mitral valve pathology, LA diameters, and pulmonary artery pressure. It can even identify LV apical aneurysms, which is often associated. It can identify scarring, and these are all prognostic markers in a patient of hypertrophic cardiomyopathy. So basically, CMR is important, better characterization, better RV characterization, other abnormalities that will contribute to subaortic obstruction, as we were talking about, and anomalous insertion of anterolateral papillary muscle directly into the mitral valve producing a mid-cavitary muscular obstruction. We keep on talking about sudden cardiac death, especially in young people, especially in athletic people. And this slide is again important for the juniors. Other than hypertrophic cardiomyopathy, you have possible cardiomyopathy, we have coronary artery anomalies, and issues like arrhythmogenic right ventricular cardiomyopathy or myocarditis. So these are all possibilities to consider when we differentiate the causes of sudden cardiac death in the family or risk of sudden cardiac death in the athletes. These are some of the newer genes which have come up: the myosin binding protein, alpha tropomyosin, and troponin I, C, and T, which are important for genesis of hypertrophic cardiomyopathy. It can be obstructive, it can be non-obstructive. Mutations might be pathogenic. There can be mutations of unknown significance. And interestingly, again, mutations can help us identify storage disorders, like, as I said, Fabry's disease. Treatment: risk of sudden cardiac death, implantable cardioverter defibrillator, heart failure, progressive heart failure, recurrent obstructive features, septal myomectomy or septal ablation is the treatment of choice. Again, Indranil will highlight on the recent advances: advanced heart failure, transplant, and for atrial fibrillation, anticoagulation ablation. Friends, hypertrophic cardiomyopathy was considered a very ominous diagnosis in the past. Lot of misunderstandings, both in the clinical profile and management. I remember when we were house staffs under Professor Mundita Basu, Madam told us that very often juniors prescribe the medicines which are exactly contraindicated for the management of HCM. From the medical management perspective, we need to fluid resuscitate the patient, use beta blockers, decrease the inotropicity, and decrease the dynamic obstruction. Because more the inotropicity, more the contractility, more is the degree of outflow tract obstruction. I think this is a summary slide which Indranil can take up from here, because we need to diagnose the case from history and physical exam, which Tista possibly has done with some credit. We have ECG equals CMR for the diagnosis. Apart from this, parallelly, we have genetic testing. And if the genotype and phenotype both are positive, diagnosis is documented. If the genotype is positive and phenotype remains insignificant, surveillance is important. I think Indranil should discuss the case before we have comments from the audience. Right.
Thank you, sir. HCM, basically, for the postgraduates, the most important differentiation that there is an LVOT obstruction. That is the main. We have to first classify all the cases as a syndrome. So here the syndrome is an LVOT obstruction, and mainly here it is a dynamic obstruction, and you have to qualify, quantify, or differentiate it from a fixed obstruction, that is a subvalvular aortic stenosis. So that is the clinical thing which we have to ask. And for the clinician perspective, HCM is a diagnosis of exclusion. There are different phenocopies, that is diseases which have the same pathology of a left ventricular hypertrophy, and which we have to differentiate from HCM. We have the systemic hypertension leading to LVH. Then we have different storage disorders. Then we have different infiltrative disorders. But one thing we have to remember, that most of these diseases which we see, that their hypertrophy is concentric. Whereas in HCM, sir mentioned was just once that the obstruction can be at any level. It can be at the LVOT obstruction level, it can be at the mid-cavitary HCM level, and it can be even there can be an apical HCM also, which is known as the Yamaguchi syndrome, where the pathogenesis of LVOT obstruction is not very much. But in the common cases which we find there is an asymmetrical septal hypertrophy. You can see here, sir mentioned about the LV wall thickness of more than 15. There is another thing, that is the septal to the posterior wall thickness of over 1.3 in patients who are normotensive, or over 1.5 in those who have systemic hypertension. So there is an asymmetrical hypertrophy leading to a spiral shaped septum, which is developing into this, causing this obstruction. She described the history as shortness of breath, which were as the main chief complaints, and also angina. Now, why is this causing this shortness of breath and angina? The shortness of breath in HCM is mainly occurring due to diastolic dysfunction. The ventricle is not contracting very much. There is restrictive feeling. It is poor and poorly non-compliant, and leading to this diastolic dysfunction. Basically, shortness of breath always occurs due to pulmonary venous hypertension. Now, this pulmonary venous hypertension is occurred due to diastolic failure in these cases. Whereas in cases of valvular heart disease, we find that the left atrium is non-compliant. There is back pressure leading to pulmonary venous hypertension, and there leading to fluid accumulation in the lungs. And so we have this expression of increased work of breathing leading to dyspnea. Other findings which can be seen in HCM, not very much prominent in our cases, were dizziness and syncope. Now, this syncope could have occurred due to this LVOT obstruction, or more dangerously, it could have been occurred, but maybe this was a ventricular tachyarrhythmia, a VT, which led to an aborted SCD, aborted sudden cardiac death. But palpitations may occur more commonly with atrial fibrillation rather than ventricular arrhythmias. From the examination, we found she is described as bifid pulse, or better known as pulsus bisperiens. Normally, we have the normal pulse have a percussion wave, and there is a tidal wave. So what happens in bisperiens? There is this hypertrophic septum, and during the systole, this hypertrophic septum is bulging into the left ventricular cavity, causing it to shorten further. So you see, first there is this percussion wave, and during this obstruction phase, during the systole, there is sudden fall in pressure, which is leading to truncation of the wave, and that's why there is this trough. This trough is occurring here. And after the obstruction is over, again due to this ejection, again there is the second wave. Now remember, these pulsus bisperiens, both of these are occurring in the same phase of the cardiac cycle. And this is how you differentiate from the other pulses. Here she mentioned that JVP was prominent. She didn't mention the pulsatile nature, that which wave was more prominent, the A or C waves. CV waves was most prominent here. Basically, in HCM, generally, if failure doesn't intervene over and above it, JVP is not encouraged. Sometimes the septal hypertrophy can cause this reduced RV distension, and so the RA is contracting with a greater force. So there may be an A waves the A waves is prominent. Usually, remember, the JVP may be normal, or there may be a prominent A wave. But remember, in most of these cases of HCM, there may be superadded atrial fibrillation, which leads to disappearance of this A wave. The palpation of that is the apex beat, we found the double apical impulse. The double apical, this is the apex cardiogram. Here we can see that there is the double at the second apical, the second impulse is occurring due to forceful left atrial contraction. The first is occurring due to forceful left atrial contraction against the non-compliant ventricle, which is corresponding to the S4. So this is the first, and this is the second, and this total leading to the double apical impulse. But more commonly in cases, we find the triple ripple or the triple apical impulse. Now remember, in other cases like post AMI, we get a palpable S4 and we get an apical impulse. But in HCM, this is one of the very unique condition where we get a triple apical impulse. That is a palpable S4 followed by the two heart sounds which corresponded to the Bisperian's pulse. That is a late systolic buzz leading to the first and then to the two systolic contractions. First was which was occurring normally, then the obstruction is occurring, and after the obstruction is over, the third one. So the triple ripple, if you get a patient with triple ripple, then always think that HCM should be the first possibility. Another, very rarely we can find the quadruple ripple also, where due to the left ventricular filling, there is another diastolic sound, that is the S4, that is S4, S3, and then the two systolic sounds. Coming to the auscultation, S1 is normal in all cases. S2, there may be normal split. There may be paradoxical split also, rarely, if the A2 falls more below the P2. S3 gallop, usually not heard, but may be seen when patient has proceeded to heart failure, that is the left ventricle is decompensated. S4 is more or less heard because of the atrial systole against the hypertrophic ventricle. She described two murmurs here. One was the murmur of mitral regurgitation. How far I discerned, one was the murmur of the mitral regurgitation, and second was the murmur due to the LVOT obstruction, due to the gradient. Here generally there is a crescendo decrescendo, hollow systolic murmur may be heard. These are the common findings which I see. She found something else. There is a crescendo decrescendo hollow systolic murmur best heard at the lower left sternal border of the chest. This is the murmur which is occurring due to the obstruction. It may radiate to the base of the heart. Now here you have to differentiate it from the mitral regurgitation, because the posteriorly directed mitral jet, it also goes towards the base of the heart. And sometimes it may be associated with a systolic thrill in the left lower sternal border also. Now, why I'm continuously saying about this dynamic LVOT obstruction? Why is this occurring? The increase in septal thickness, it is narrowing the LVOT, leading, and so the blood jet, it is going instead of along the mitral valve, it is going across the mitral valve. And so there is abnormal movement of the mitral valve leaflets. This is called systolic anterior motion of the mitral valve, because of the displacement of the anterior mitral valve leaflet into the LVOT. Now, here the SAM does not occur as soon as because I was already saying that the LVOT obstruction is occurred after some time. Why is it occurred after some time? Because the SAM is occurring when the mitral valve pressure has the pressure of the LV has increased more of the aorta. That is, the ejection is occurring, and that is the time when the SAM is occurring. So there is some gap. Now, another thing which is leading to the LVOT obstruction is there is alteration in the structure of the mitral valve because of elongated leaflets and displacement of the papillary muscle and or the valve apparatus anteriorly. And here another thing has to be remembered, that she mentioned about the systolic thrill. The thrill always occurs when the blood is flowing anteriorly. Here the tricuspid regurgitation, it can occur also on the left sternal border, but tricuspid regurgitation does not occur due to a thrill, because here the blood flow is going posteriorly. The blood here is going anteriorly in our case. So we are getting a thrill. And these structural changes render the valve liable to unnatural flow vectors, which leads to the murmurs. You can see from this echocardiogram, these are two still pictures. Here, this is the systole, and here the mitral, the leaflet, it is going towards the septum, IVS, and that towards the IVS, and it is called systolic anterior motion. And here This is the gradient of the aortic stenosis, that is the fixed obstruction. You can see the spike and you can see the sawtooth pattern of the obstruction in the HCM. The HCM, there is a difference, not only about the difference of the gradient. The gradient here is about 70, here the gradient is somewhere around 25. Basically, the gradient of HCM should be more than 30 and above 550. When it goes above 50, we have to do some intervention. And below that, only management with medications is sufficient. But also see how it is, how much sharp is the gradient of the HCM. She described about the dynamic maneuvers, which is very important to distinguish it from a fixed obstruction. So commonly we do two things in our wards. One is Valsalva and another is position change. These here you can identify differentiate it from the aortic stenosis. What happens in aortic stenosis during the squatting? There is increased when the patient is squatting. There is increased venous return to the heart, so the left ventricular volume is increasing, and the left ventricular volume is increasing. So more volume is ejected into the aorta, and hence the murmur during squatting. The murmur of aortic stenosis is increasing in intensity. But conversely, already the ventricle size is decreased, and ventricle size is decreased in HCM, and there we are causing there is the outflow obstruction. There will be decrease in the intensity of the murmur. Another thing, if this is I was mentioning about subvalvular obstruction. There may be valvular obstruction also. Valvular obstruction, always remember, in a valvular aortic stenosis, another thing is the ejection click. Unless and until the valve is totally degenerative in a 70 years old male like that, there will be ejection click should be heard. And during the standing, the aortic stenosis murmur decreases, whereas in hypertrophic cardiomyopathy, the intensity of the murmur will increase. So by this standing to squatting, the squatting to standing, by this the murmur, by looking at the intensity of the murmur, we can distinguish it from AS and HC. Another thing we have to identify is the mitral valve prolapse. That is, she mentioned about the mitral regurgitation murmur. Basically, during squatting, there will be the murmur intensity will decrease in HCM, whereas in cases of mitral valve prolapse, the murmur it will not increase. It will not the intensity will not decrease. The duration of the murmur will decrease. And also the MVP, there are a number of clicks, so clicks will be heard later into the cycle. Whereas in case of standing, the murmur of HCM will increase. Here also the murmur will not, there is no change in the intensity, but the duration of the murmur will increase. Duration of the murmur will increase in case of mitral valve prolapse. This is the echo which I show. This is the echo of a patient which we could not. I'm just showing it. You can see from here. See the grossly hypertrophied ventricles. This is the IVS and this is the posterior valve. You can see from here it is grossly hypertrophic, and from here you can see the systolic anterior motion which is occurring. During the systole, when they are coming towards the motion, the mitral valve leaflet is going towards it. You can see from this is the apical four-chamber view. Again, we can see very obviously LV hypertrophy and the systolic anterior motion. You can see and it is striking against the valve, and thereby it is both of these mechanisms are causing these LVOT obstructions. And here, by putting a continuous wave Doppler against, you have to identify the maximum level of the obstruction and identify, and they are putting a color wave the continuous wave Doppler, you can find the obstruction. for the management part, sir was telling about the medications and ICDs. So that is the most important, that which patient you have to refer for a need for an ICD. We have the AHA guidelines and we have the ESC guidelines. And firstly, we have got an HCM, that is a sudden card, that is for risk stratification. We have the SCD risk calculator. And if there is a patient with HCM with a family history of sudden cardiac death, which we found in this case, there is a massive LVH more than 1.5, unexplained syncope, that is, which may be due to an aborted SCD or an apical aneurysm or an LVEF less than 50%. Remember, in HCM, regularly the LVEF is more. It is usually more than 50%. But if the LVEF is, that is the ejection fraction is less, that means that there have been episodes of heart failure which is continuously occurring in this case. So with these findings, that is, this is a class 2A indication. There is, remember, there is still no class 1A indication for HCM. It is a class 2A indication for putting the ICDs. And for that is the 2022 ESC guideline. They have slightly changed it. The similar apical aneurysm LVEF is there, but they have some other finding, that is they have put MRI also in our in the diagnostic criteria, where if there is an extensive late gadolinium enhancement or an abnormal BP during exercise or a positive sarcomere mutation, then it is a class 2A indication. Now, medications, generally beta blockers and CCBs, these are the medications of choice. And obviously we have to not give nitrates or diuretics unless and until patient has gone into a congestive failure. Nitrates are contraindicated, but there are certain therapeutic medications which have come into the vogue now. For the in fact, the mavacamten, which is a allosteric inhibitor of cardiac myosin ATPase, which has been FDA approved 3 years back in 2022. Now, who are the patients which we have to give mavacamten? That is patients who have got maximum symptom, in spite of giving the maximum doses of beta blockers, calcium channel blockers, and diisopyramide. And patients, we have different trials. The trial was the Explorer HCM trial, where patients with NYHA class 3 patients were investigated, and there it was found that patients with obstructive pathologies, that is HOCM, after 4 weeks therapy with mavacamten, there was improvement on LVEF and also the functional class. But more commonly, in spite of the HCM, we have the ASH or the non-obstructive variants which we find clinically. How is it working or not? There was this phase 2 clinical trial, the Valor HCM trial. There we have found that still now, where also where non-obstructive pathologies were also considered, but still not very much good results were come out. But other trials are also undergoing. The Maverick trial, where much sicker patients, that is those patients who are class 3 or class 4 symptomatic, who are hardcore candidates for alcohol septal ablation, these patients has been recruited, and the results are still awaited for the Maverick trial. Now, coming to just these are the things which we have to refer to the subspecialty that is for the intervention, that is alcohol septal ablation and septal myomectomy. After angio, we do identify a big septal vessel, and we inject alcohol, leading to, but this is fraught with risk, because there may be chances of arrhythmias, and also there may be bundle branch blocks which may lead to pacemaker in the futures. So, however, in younger patients, alcohol septal ablation is a choice, whereas in older patients, we have to go for the CTVS opinions and septal myomectomy, which is a treatment choice. Gene therapy, different trials are coming up, mainly gene replacement. All the trials have been done on gene replacement, but other trials have been come for modulation of signal pathway with the then allele specific silencing or genome editing by the the CRISPR-Cas9 mutation by different changes. So these have not come up yet, but these are futures which can come up, and for that HCM may be treated with better purpose. Thank you.
Dr. Indranil.
Thank you, Indranil.
May I
I
ask
think that
one
was a
question?
good analysis of the case.
May I ask one question in relation to his last slide? Dr.
Yes.
Indonesian. Mavacamten, is it available in Indian market? If yes, what is the cost? And will it reduce sudden cardiac death? Is there any study regarding that thing?
Available. Available.
Dr. Sen,
Mavacamten, sir, is available now. It is present. There are doses of 5 milligram, 10 milligram, and 15 milligram, which we have to up titrate. It is available. It has come up available. However, not very much available in government setups up till now.
What is the cost of it? Dr. Sen, cost
Sir,
of
I'm
it?
not very much aware of the therapy cost.
Okay. And will it reduce the incidence of sudden cardiac death? Do you have any idea? Or the
No, sir.
studies?
It has sudden cardiac death. It has already the parameter in the different trials which has come up. All the parameters we went for the HCM questionnaire or the Kansas City questionnaire, where there was the reduction was in the LVEF or the NYHA class. But whether it has changed the incidence of sudden cardiac death, it has not come up because probably because the trials have not yet progressed to such a duration where we can see that
right.
there is a prognosis of that.
Yes,
Trade name কি?
thank you.
What is the trade name?
Trade names are probably Coriza or something like that.
Our chemical name?
Chemical name is Mavacamten.
Mavacamten.
Mavacamten, and trade name is probably Coriza.
No, chemical name একবার বলো।
Sir, Mavacamten.
Mavacamten.
ওই সিটা বোধহয় সিটা উচ্চারণ হবে কে এর
লাস্ট
মতো।
স্ক্রিনটা একবার দেখিয়ে দাও ইন্দ্রনীল, লাস্ট স্ক্রিনটা একবার দেখিয়ে দাও।
Last slide, sir.
লাস্ট স্লাইডটা দেখিয়ে দাও,
Yes, sir. Yes, sir.
একটু অ্যারো দিয়ে দেখিয়ে দাও।
তবে পার্থদা,
Yes.
what we understand from the mechanism of action, this drug probably has negligible benefit on erythrogenicity.
Right.
আচ্ছা হ্যালো
One more question.
হ্যালো একটা কথা বলবো।
বলুন স্যার।
আচ্ছা আমি একটা ছোট্ট করে গল্প বলছি। হ্যালো আমার
বলো স্যার। হ্যাঁ তাড়াতাড়ি বলো।
আচ্ছা এই গল্পটা 6 ফেব্রুয়ারি NEM এ বেরিয়েছে। 51 বছরের একজন অ্যাথলেট, সে তার পারফরমেন্স গ্র্যাজুয়ালি ডেটোরিয়েট করছে। Am I clear? 51 বছর অ্যাথলেট, অলিম্পিকে দৌড়েছিল, এখন তার পারফরমেন্স ধীরে ধীরে ডেটোরিয়েট করছে এবং এক্সারশনাল ডিসনে হচ্ছে। সে আমেরিকান একজন কার্ডিওলজিস্টকে দেখিয়েছিল, সে ইকো করে বলেছে হাইপারট্রফিক নন অবস্ট্রাকটিভ কার্ডিওমায়োপ্যাথি। তাকে বিটা ব্লকার ক্যালাপটিন দেওয়া হয়েছে, কিন্তু তার কোনো প্রগ্রেশন হয়নি। সঙ্গে তার অ্যাসোসিয়েট ছিল টানেল সিনড্রোম, রোটেটার কাফে আর হোর্সনেস অফ ভয়েস, কিন্তু কিছুতেই ক্যালাপটিন আর বিটা ব্লকার দিয়ে তার কোনো ইমপ্রুভ হচ্ছে না। তখন একজন সিনিয়র কার্ডিওলজিস্টের কাছে সে ইয়ং কার্ডিওলজিস্ট নিয়ে গেল। সেই সিনিয়র কার্ডিওলজিস্ট পেশেন্টটাকে দেখলো, দেখে ইয়ং কার্ডিওলজিস্টকে বললো, পল্টু ডায়াগনোসিসটা ভুল করেছি, নেক ভেন্সটা দেখ। নেক ভেন্সে দেখালো হুসমল সাইন প্রেজেন্ট, ইন্সপিরেটরি কোলাপস হচ্ছে না। বলছে ইকো যাই বলুক, এটা হাইপারট্রফিক নন অবস্ট্রাকটিভ কার্ডিওমায়োপ্যাথি না, তুই MRI কর। এটা হচ্ছে অবলিটারেটিভ মায়োপ্যাথি, এটা হচ্ছে অবলিটারেটিভ মায়োপ্যাথি। তারপরে মানে রেস্ট্রিকটিভ কারণ আছে। MRI করলো, MRI করে বেরোলো এটা রেস্ট্রিক্টেড কার্ডিওমেট্রি। তারপরে ব্লাড টেস্ট হলো, এন্ডোমায়োকার্ডিয়াল বায়োপসি হলো,
Amyloid.
বেরোলো অ্যামাইলয়েড। সো আলটিমেটলি ক্লিনিক্যাল মেডিসিন কে কেউ সুপারসিড করতে পারবে না। থেকে বেশ কিছু বছর আগে জার্মান ফিজিশিয়ান কুসমল আবিষ্কার করেছিল কুসমল সাইন is still best sign to differentiate between obstructive cardiomyopathy and restrictive cardiomyopathy. Still in the February 2025 in Massachusetts Man Greatest Hospital.
সত্যতার কথা অনুসারে বলি, সত্যি ক্লিনিক্যাল মেডিসিন তো কখনোই আমরা বলি না, বিশেষ করে সিনিয়ররা, যে অবসলিট হয়ে গেছে। তো যে ভদ্রলোক ওই কেসটা দেখেছেন, তিনি যদি জেবিপি না দেখতে পারেন কার্ডিওলজিস্ট, তাহলে তো ব্যাপারটা একটু, ক্লিনিক্যাল মেডিসিনটা সত্যি উনি ঠিক মতো না দেখলে শুধু শুধু দোষ দিয়ে তো লাভ নেই।
শুরু তো করে ইকো দিয়ে।
ইকো, তারপর উনি হয়তো ইকো করেছেন।
It is okay with permission of the chair. One line I am just adding. With permission of the chair.
ভুল হয়েই থাকে, সেটা ঠিকই আছে।
With permission of the, let us forget about this thing because we are not going to any controversy. I like to request, I like to just one comment. Indranil has done a marvelous job. Dipanjan has summarized the thing in a very nice way and the presenter was excellent. This is the first thing. And my second point is the Indranil, তোমার এত ভালো লাগলো because you are with me for a long time.
Thank you,
তুমি
sir.
আমাকে একটু বলো তো what is beat to beat variation of the systolic murmur in cardiomyopathy for the students? ওটা কি hypertrophic cardiomyopathy যারা obstruction থাকে তাদের ক্ষেত্রেই প্রযোজ্য না নন obstructive এর ক্ষেত্রে প্রযোজ্য? ইন্দ্রনীল।
Yes, sir.
ইন্দ্রনীল।
Yes, sir.
আমি যেটা বলছি আমাদের সময় যেটা হতো বিট টু বিট ভেরিয়েশন অফ দ্য মারমার আমরা বলতাম বিকজ অফ দ্য ডাইনামিক অবস্ট্রাকশন।
Yes, sir. The beat to beat is occurring due to this with the same pathology of the LVOT obstruction.
আচ্ছা আচ্ছা, this is number one. And আমরা তো এখন আর কার্ডিয়াক ক্যাথ করি না, না?
Sir, that is another thing which I'm that little bit saying on this, because this is another very much thing which we could have identified. If I had done this, then I would have identified it from the this aortic stenosis, that is the LV to aorta pullback or the broken bird phenomenon, which I think Professor Rai is describing. But if you can, that is if there is an extra systole, that is a post extrasystolic potentiation in aortic stenosis, then after the next systole, the pulse rate will be more. Not the rate, the volume will be more, but in cases of HOCM, it will be less. So this is a very much important thing which we could have identified.
So, and you will never miss restrictive cardiomyopathy. You will never miss restrictive cardiomyopathy. My idea of telling is that
cardiac cath we are doing less, but had I could have done this, but this is the Brockenberg is classically as a LV to aorta pullback, but it can be seen with if you can very much see with this pulse. So you can finding this pulse very much.
Yeah, there is one is important and another is sometimes
that is very much
Barnum's effect
important thing, sir. It is a very much clinical important thing.
Thank you
presented on this.
Thank you very much. Thank you.
Dr. Indranil, another question from my end. So what is the role of verapamil nowadays? Because in our time we used to use verapamil. Okay. So whether you will prefer beta blocker?
Yeah, first line choice of is beta blocker. First line choice is beta blocker, but if there are any contraindications to beta blocker, like patients has got some other peripheral artery disease, patient is a known case of asthma, then verapamil or CCBs can be preferred.
Okay. Role of amiodarone?
So amiodarone doesn't have any role in this case unless and until
more for prophylaxis of
more for prophylaxis it can be given, but they are also beta blocker first line of choice.
Rather, sir, I would ask Indranil, what would be the choice of beta blockers?
That is a good
Choice of beta
question.
blockers.
Choice of good. That is good question.
We can give
Which beta blockers
metoprolol
should
or
we use?
bisoprolol, that is cardioselective beta blockers.
Okay. Okay.
Any indication of Norpace?
Norpace.
Keep this.
Sir, can you repeat?
Not pace, not
NORPAC, Norpace.
Diisopyramide.
Diisopyramide
Yeah,
can
yeah.
be also given. Yes,
Yeah,
it is
yeah.
also
There
given.
is a role.
I haven't
There is
used
a-
it, but diisopyramide is definitely a treatment option. Definitely a treatment option.
And one more thing I want to know, absolute
One question
indication
from
of
North Bengal.
septal myomectomy. Not doing alcohol ablation, but first indication only septal myomectomy. You are telling
Septal
first medicine,
myomectomy.
then alcohol ablation, then septal myomectomy. What are the subsets we will choose to do septal myomectomy?
Okay, septal myomectomy. Firstly, the older age patients, then patients who have got a very gross concentric hypertrophy more than about 1.7 like that, and patients which where initially we have a right bundle branch block. Because because in cases of, if we can, while doing the ASA, if the left bundle is also blocked, then the patient will totally go into CHB. On table, the patient will go into CHB. So if there is this is basically RBB is a benign phenomenon, but in this case, if there is an RBB, then septal myomectomy is always the treatment of choice, and ASA can't be done.
Okay, thank you, Indranil.
Wonderful. I think these are good learning points.
Yeah,
Yeah.
very practical point.
Sir,
Questions
একটা
now.
প্রশ্ন করবো from North Bengal. How common is cardiac MRI now in Kolkata?
Quite common, I think. Very commonly done.
Because we have only one center in Siliguri performing, and that also not very user-friendly rates.
So
Kolkata
Professor Sarkar, we have almost come to an end.
এই কোশ্চেন গুলো দেখে নাও, চ্যাট
হ্যাঁ।
বক্সে কোনো কোশ্চেন আছে?
আমাদের চ্যাট বক্সের দীপাঞ্জন একটু দেখে নাও, কোনো স্টুডেন্টসদের বা অন্যান্য ডেলিগেটসদের কোনো কোশ্চেন আছে কিনা।
আজকে
Then we will
শিবেন্দু
come
কোনো
to an end.
শিবেন্দু কোশ্চেন করছে না, নেই?
চ্যাট বক্সে কোনো কোশ্চেন নেই?
না।
Okay. Okay, then I think we had a very good discussion. Both we must congratulate Tisha and also Dipanjan and Indranil for their nice presentation. And I will now ask Professor Partho Sarkar to please give a vote of thanks. Vote of thanks.
Yes, basically did the job.
Thank you, Chairman, sir, to ask me to give the vote of thanks. Actually, it is an excellent presentation of the history by Dr. Tista Har, second year PhD from NBMC. Thanks to her. Then definitely a very good elaboration of the subject by none other than Dr. Dipanjan Bandyopadhyay, Professor HOD of North Bengal Medical College. My sincere thanks on behalf of this ICP for this taking the taking the privilege or whatever you say. We are privileged to have this topic offered to North Bengal Medical College. So a huge thanks to Professor Dipanjan Bandyopadhyay. And already Dr. M.K. Rai said Indranil was with us in National Medical College for quite a long time. Very humble person, has developed over so many years. And then in North Bengal, as a cardiologist, has done a brilliant job with his explanation of the clinical features. So a big thank you to Indranil for this sincere effort. And now I sincerely thank all our secretary also, though the organizers are Professor Kormokar, PS Kormokar, Professor Rothin Sarkar, and the team of coordinators like Professor M.K. Rai, then Dr. Pathak, then Dipanjan himself is also a part of the coordinator, Dr. S.V. Ganguly, and all the
Dr. Paramita.
audiences of the delegates who have attended this meeting and have enriched their knowledge. So thanks to all the audiences and thanks everybody. So over to Dr. R.N. Sarkar, please.
Partho,
Yes.
I think in March we have 5 Sundays. We'll let all the faculties know about our next program.